Welcome to the Protocol, Procedure, and Patient Acceptance of Implant Dentures. It's being presented by Dennis Urban, CDT, Director of Clinical Education for National Dentex. And with that, I'd like to recognize Lisa Wasoko. She'll be joining us as a panelist. She is the Director of NDX Education Center, and Dennis Urban is our Director of Clinical Education. And a little bit about Dennis. He brings 40 years of dental technology field experience, including lab management, technical training, sales and marketing, product development, and quality assurance. In addition to being a seasoned dental lab manager, Dennis has been an eminent lecturer worldwide since 1985. His lectures and courses span many areas of dental technology, including denture setups, digital technology, denture processing, lab management, implant overdentures, and bar design protocol, all on 4 and 6 case planning and chairside conversions, shade communication, occlusion, and soft liners. Basically everything in dentistry. His technical articles have been published in publications across the US, Canada, and Europe. Dennis has been president of both the Long Island Dental Laboratory Association and Dental Laboratory Association of the state of New York. He has served, he currently is serving, he has served as the Cal Lab board member, and he's currently the board president on the National Board of Certification and serves on the advisory board for IDT magazine. Okay, that's a lot about Dennis. Man. He's an amazing guy, and take it away, Dennis, and educate away.
All right, thanks, Jessica, and thank you everybody for joining us tonight. Man, you make me sound old, you know, but it's a lot of experience, a lot of years, and I think I'm getting the hang of it now. But yeah, thank you for taking the time to join us tonight on our webinar. You know, tonight we're going to discuss, as Jessica mentioned, protocol, procedure, and patient acceptance of implant dentures. So we have a lot to cover. I'm going to cover, overdentures, hybrid type cases. We'll go over everything in between, by registrations and setups and denture setups and protocols. So let's get started here. So we have a lot to cover here, and we're going to talk about science, technique, and application. So tonight we'll go over mill bar designs with overdentures, implant overdentures directly over implant abutments, various types of attachment systems with mill bar designs, and of course, hybrid design protocol and procedure, including chairside conversions on new and existing dentures. But first, we'll start with implant overdentures. And you know, I try to stress that the right materials, quality materials, and the right techniques are a reflection of your talents. It takes a long time to get to where we are. Why not use the best that's out there for your patients? You know, so, but where are we going with implant denture technology? Well, the majority of United States labs surveyed claim they had a dramatic increase in implant dentures in the last 5 years, which is amazing because the denture business is growing like crazy. Not only with implant dentures, but full cases, digital dentures, partial dentures, all around, the whole gamut. So, and dentists who would like to increase their implant dentures and hybrid business, about 70%. This is from a survey that was taken, and so that's amazing. You know, so there's more income opportunities for dental laboratories, dental technicians, dentists, and dental manufacturers. And it all starts with communication. You know, we have all these great communication tools at our fingertips, but sometimes we just can't plan a case correctly. So that's why tonight I'm going to stress communication and protocol. So when it comes to communication on these types of cases, you know, we depend on you in the laboratory, and we depend on the dentist, the surgeon, the periodontist for your clinical knowledge and training, the assessment of the patient, the appropriate treatment planning, and detailed information on the work authorization form. Of course, digital photography, pretty much with every case, and the proper materials. And from us at the dental laboratory level, the certified dental technician, we offer you our technical expertise and knowledge of procedures and materials, the appropriate feedback to you on impressions, bites, shades, etc. And I think still the #1 phone call I make in the laboratory is on impressions. You know, so it's important to get everything right on the onset, so we don't have to worry about remakes later on. So, and of course, case planning with the dentist and oral surgeon on these types of cases, digital photography, and advice on proper case planning, and getting also the implant representative involved. So when we're talking about dentures and even implant dentures, hybrid type dentures, I always try to stress a preclinical interview. And I know a lot of you do that, you know, and some of the questions on these preclinical interviews are, you know, what are your specific concerns or limitations? How long have you been a dentalist? How many dentures have you had since your tooth loss? How did you lose your teeth? And have you ever considered implants? And to further go onto this checklist, see what the patient's complaints were, the history of dentalism, what kind of support they had if they were wearing a full denture and now they want to go over to an implant denture, the stability and the retention. And we have to take into consideration, how was that previous denture made? Were there proper border extensions? Was the centriculation and VDO correct? How about phonetics? Phonetics is a big issue with denture wearers. And of course, aesthetics. People don't want to look like they're wearing dentures anymore. They want to look like they're wearing an aesthetic, high-end case that doesn't look like a denture. And we'll talk about that quality of how to achieve those aesthetics later on. And of course, occlusion and opposing dentition. So many times on, denture wearers, if they're wearing dentures for years, and they never had them relined, never had the occlusion checked, that could be a big issue. And it could be very detrimental to the bridge area and also how the patient eats. And a lot of times the denture is going to wind up in a glass jar or a glass or the top pocket. So let's talk about implant dentures and getting the ultimate results. First we're going to go over implant overdentures, and there are a number of advantages that overdentures have over complete dentures, and many clinicians believe that complete dentures are not an appropriate restoration, and instead that the minimum standard of care should be 2 implants on an overdenture. And with many implant and attachment systems on the market, the cost of an implant overdenture can become very affordable. So wherever we have natural teeth, roots, or implants, we tend to retain the bone in those areas. And this is one of the most important benefits of overdentures when compared to complete dentures. And patients who are restored with overdentures chew more effectively and have more comfort. So and for the patient, it raises their self-esteem and confidence level, knowing that they'll be able to speak correctly, eat most foods, and have a stable denture. So I'd like to start out with this quote here, and this is from Dr. Strong and Dr. Masad, and from Dental Economics. And they said that the removable implant overdenture has become a well-established option, if not the most preferred for the edentulous patient. And critical to the success of this procedure is not only an accurate impression of the implant abutments, but also extremely vital is a detail of the entire edentulous ridges. We have to capture all those anatomical landmarks, the retromolar pads, the undercuts, the full ridged, full borders, and to maintain stability and retention and deflect unwanted food entrapment around those denture margins. So it's real important to get a good impression with these types of cases. So we're going to go through a little bit of a history here and a little overview of implant dentures. Then we'll get into the heart of the information in a few minutes here. But there's over 20 million, probably 25 million Americans that are dentals now. And over the years, undergraduate programs across the country realized that 2 implants for lower overdentures are the recommended treatment choice over leaving somebody fully edentulous. And the amount of bone loss that dentistry has seen in fully edentulous patients over the years is frightening to consider. So that's for a number of reasons, and we'll talk about those reasons in a little while. Dentistry taught at that point that bone atrophy was normal. And we know now that 2 implants on the anterior mandible will stop this progressive bone loss and preserve the ridge. So what are the implant overdentures' purpose? Well, we want to create natural aesthetics. We want to enhance facial appearance, compensate for that lost soft tissue, and enhance function with the right occlusal scheme. So we'll talk a little bit about lingualized occlusion later on, which I recommend for all implant type cases. And most patients can afford one type of implant overdenture, since they're less expensive than with a fixed prosthesis. Some of the indications for implant overdentures: compromised support for the conventional denture, like I mentioned before, poor neuromuscular coordination, the low tolerance of mucosal tissue for removable acrylic base, which is a lot of sore spots and a lot of moving around, and the patient's dissatisfaction with complete dentures and desire for more stability and comfort, which they can achieve with implant overdentures. And also taking into consideration any congenital or oral defects that need oral rehabilitation. So let's look at the 3 basic types of implant overdentures. Number 1 is mainly tissue-supported overdentures, where 2 prefabricated individual attachments are utilized, and the overdenture is mainly tissue-borne. And this is really where it's important to capture all those anatomical landmarks, those full borders, to maintain that stability. And then there's this tissue implant-supported overdenture, where more implant-borne compared to the previous type, when 2 implants and a resilient bar attachment assembly should be utilized. And we'll speak about that in a few minutes, and why, when and why we should use a bar instead of having going directly to the implant. And then we have our fully implant-supported overdenture, where an attachment assembly that usually contains 4 or more implants is present, and the attachment assembly transfers all the masticatory forces to the supporting implants, and minimal flange and tissue coverage is required. So, some of the overdenture treatment strategies for deciding factors are, again, I mentioned earlier, soreness and discomfort with denture base. And we have to look at bone quantity and patient's expectations for the treatment outcome. And it's really important to have realistic patient expectations and just talk about what you can do with these types of cases, because many patients, they may want a hybrid denture, but that transition line is just too much for them, and we have to create some sort of flange and have an overdenture case instead. And some expected oral hygiene and patient compliance. You know, with an overdenture, they can take this out of the mouth and be a little more compliant with oral hygiene. And then looking at the jaw relationship and intraocclusal space, the distance between the upper and lower alveolar ridge. And we have to, all this comes into play with the expertise of dentist and lab technician for great communication. And some of the common mistakes in construction implant supported overdentures are poor treatment planning, distorted impressions, inaccurate master models, as well as a working model, a poor fitting framework, and the wrong choice of materials and attachments. We're going to go over some of those attachment choices in a little while. And when you look at the successful implant-supported overdenture, it's a stress-free fit of the attachment assembly, something that promotes good oral hygiene, biocompatibility of chosen materials. And you know, when we talk about the biocompatibility of chosen materials, that includes an acrylic base too. You want to have an acrylic base that's going to have flexural strength and the one that's going to have eye impact resistance. And functional and equilibrated occlusion, lingualized, we'll talk about lingualized occlusion in a little while, like I mentioned, and natural looking aesthetics. And the materials that are out there today, with the denture teeth out there, the acrylic bases, I mean, they look so natural. The denture teeth, or they wear just like natural dentition, and they look like, you know, they look like a crown, especially on the anterior region. There's some beautiful choices for denture teeth out there. And the absence of interference with normal phonetics. So let's talk about with or without a bar. Well, a bar can achieve distributed forces between dental implants. And you know, the direct method with overdenture attachments incorporated into the denture base without a mill bar, it would cost less and requires less vertical room. You know, with a bar, you're going to need some more vertical room. And the final case design is determined by what we have to work with intraorally. Both methods require support from the tissue and the attachments. And keep in mind that the denture rests on the soft tissue and the attachments act only as a retentive element, preventing the denture from dislodging. So let's look at the advantages of the overdentures. We talked about some of the advantages before: preserving bone, better chewing efficiency, peace of mind, security, stability, and comfort. But once we introduce attachments into the case design, we gain 3 additional advantages. And the overdenture will be more stable than a complete denture, which leads to greater comfort and better aesthetics. So now we'll be able to determine how occlusal forces are handled, and you'll have the choice of rigid and resilient attachments from which to choose. And you can decide if the overdenture will be supported more by abutments, or if the ridge will handle more of the load, and then we can achieve superior aesthetics. You know, so we're no longer relying on a closed palate and heavy extended flanges on some of these types of cases to hold the denture in place. So we must be sure that the flanges do not engage any tissue undercuts more than about 1 millimeter. And then if so, we'll shorten the flanges so they don't create a different path of insertion than those indicated by the attachments. So it's best to begin each case by doing a denture setup and making a putty matrix of that denture so it can guide us when placing the attachments. But we'll get into that in a little while. So let's look at this picture here. So on the left-hand side, we have a picture of this patient without a denture, one with an implant hybrid case. But even with the implant hybrid case, the patient's mouth is too sunken in, and it had a big transition zone. So when the patient smiled, you could really see where his gingiva was. And on the far right, you see him with an overdenture with a flange, which looked the most natural. You know, so the overdenture with the flange was the way to go with this type of case. So let's talk about implant dentures, individual attachments or a bar with attachments. How do we choose? Some of the considerations with attachments only, well, an ideal ridge structure is needed. You know, for instance, a lower full denture on a patient with an ideal ridge and good bone structure can easily have overdenture attachments placed into the final denture without the use of a milled bar. So we want to make sure the metal substructure is placed internally for strength, And there's a lot of choices for different substructures now. And I'll show some pictures of that in a little while. And an upper denture will be functional with just attachment if the patient's bite isn't an ideal class 1 occlusion. We start getting into different types of occlusion schemes like class 2, class 3, it could be pretty tricky with just attachments. So deciding factors for bar assembly. Often the anterior ridge on an upper has mobility if the patient is not an ideal occlusion. And this causes a mesiodistal rock that can put all the stress on the attachments. And then this is when we consider a milled bar assembly. So if the patient has a flat ridge, there'll be no tissue support and all of the pressure will be on the attachment. So if possible, a fixed case is better. You know, a bar with horizontal lock attachments, they act as sort of a fixed patient removable prosthesis. So let's look at the protocol for an overdenture. So first of all, we start off with a preliminary impression of the healing caps. We'll make a custom tray for that final impression. And then once we get that final impression for the final model, we'll make a bi-rim. And if we're doing a bar, then we'll make a verification jig. You know, that's part of the protocol. So once we get that by registration, we get it back at the laboratory, we're ready to do a setup or try-in. First, before we even do the setup, I'll get an internal strengthener made. It could be a mesh strengthener, a chrome cobalt strengthener, or something else that's going to really support that denture and stop it from breaking around where the attachments are. And the final visit is a finished denture with insertion and attachment connections. Now, these attachment connections can be either done in the laboratory, processed in the laboratory, or done chairside. So there's a lot of attachment choices out there. There's so many different attachment systems on the market. I have a couple of the more popular ones today we're going to talk about. And one of the more popular ones is the locator attachment. So, you know, we do a tremendous amount of locator overdentures in the laboratory, and they work out great. And they're so diversified. So there's a lot of choices. You know, there's cast 2, root attachments, milled bars, for implants directly to the implant. So there's a lot of choices when it comes to locator attachments. And it's compatible with virtually all implant systems on the market. And, you know, even with digital dentures now, you know, we're able to use locator scan bodies just to scan those scan bodies and then merge all that information into our 3Shape or Exocad or whatever software system you're using to design a digital denture. And those digital dentures, as you can see on the far right, on the top picture there, it creates a void where those housings are, and with just enough room that you can cure those attachments in the denture intraorally or in a laboratory. So I love the new digital denture technology. You know, I'm not even touching on that tonight, but I touch on it a little bit here, but even with virtual articulations and denture setups, and it's just amazing what can be done now with digital dentures and with digital technology on removables. And this is just a photo of a scan with the scan bodies. Another photo of a scan here, and just allowing doing a setup here. We're going to be doing a setup, and the final case is going to have that room for those processing those attachments. And if you have divergency issues, you know, with implants, Locator RTX abutments, they take care of that divergency issue up to 60 degrees total divergency, which is great. So, you know, many times those implants aren't divergent and not straight and parallel, and we have to consider these types of attachments. So why a regular locator compared to an RTX? Why I just mentioned. So, you know, you don't want to have a regular locator attachment on something that's divergent. What's going to happen? That attachment's going to wear out pretty quickly. So you want to have those specific attachments that you utilize for divergency issues. And there's a lot of different choices. You know, there's different levels of retention on these types of attachments that really work out well for the patient. And, you know, so you have your choice of retentive values on these types of attachments also, just like you do on the regular locator attachments. Another popular attachment out on the market, it's been out for many, many years, and we still use them quite a bit, is the ERA attachments. You know, they really work out well for overdenture cases. This particular case is just showing here some of the protocol here. We had a final impression taken with the impression analogs, poured a soft tissue model on here. And this was actually, we had a verification index and we had a bar made. And we were able to screw those 2mm threads into the bar for those ERA attachments. So before we did, we processed the denture, did the setup, we had a framework made, as you can see here. This is going to be a horseshoe type frame. So we wouldn't have to worry about that pallet cover, having the entire pallet covered with acrylic or anything like that. This is going to be comfortable for the patient. It's also going to be able to support that overdenture. And you can see after the case is processed on the lower right here, we have the framework and the process attachments. I probably would, this design here, I probably would have done this a little bit differently. I probably would have brought some of that mesh more around towards the where the attachments are to give it more support. But this wasn't the case that I happened to do here. So again, this is the final process here. Look how nice it looks. We're able to snap in different retentive values for these types of attachments. And here's the final case in the patient's mouth. Very nice case. So we have our ERA, we have Locator, then we have one of my favorite attachments is called the OT Equator. It's a little bit of a smaller profile compared to the Locator attachment. And it's the same, pretty much falls in the same guidelines with castable, for implants, for mill bars, and it's compatible with all implant brands. And it has cuff heights from 1 to 7 millimeters with a standard 2 millimeter thread like the other attachments. So one of the reasons why I utilize the Equator attachments is when I don't have enough room intraorally, this has a smaller profile. So when you're setting denture teeth over attachments, every millimeter counts, so, and you don't want to grind that denture tooth too thin because you're going to lose shade integrity, you're going to lose strength also. So you can go with a type of attachment that will allow you more room while you're processing these cases. This is the way to go. So Equator is a nice attachment. You can see the differences in size. Might not look too dramatic here, but that little bit of room, it can mean a lot when you're setting up denture teeth over a bar or over an attachment. And this is OT Equator, the attachment being processed intraorally. See how nice that looks here. And again, different retentive values you get to choose from. You can see the difference again between the sizes. We've done that from the OT Equator and the Locator. Both attachment systems are great. Sometimes I just use a smaller profile attachment. So this next case I'm going to show here, this is an overdenture bar case that was started by another laboratory and was given to me because this laboratory just wasn't having success with this case here. So what we're doing here with this type of case, we're making a bar. So did a verification index and make sure everything was fitting correctly. And then we had the bar made. And so I did a lower denture setup and I also had a framework made. And internally on the Denture Setup, I actually incorporated the framework. So this is the bar with Equator attachments on it. And this is the waxed up tri-end where I incorporated the partial framework, and I processed the attachments right to the mesh partial framework strengthener, as you can see here. Everything fit well and went right to a finish on it. This is the finished denture, as you can see on the tissue side. Great support, worked out really well. So we have the Equator attachments over a bar with internal strengtheners. So this is the way to go if you're going to do it, this type of implant overdenture case. And we mentioned before the different framework strengtheners. I say the majority of the time I'm using a chrome cobalt or a metal mesh framework strengthener, but there's a lot of other options out there. And you could either cast these in the laboratory, we used to cast these internal strengtheners ourselves, but now we have our partial department do this for us, or our partial laboratory cast these for us. And there's also digital technology where you can do laser sintering with these partial internal strengtheners also, which makes things a lot easier. All you have to do is scan the model, design it, takes maybe 10 minutes to design, and we can have laser sintered partial frameworks or internal strengtheners. And then we have other options too when it comes to framework options. And those are, the super polymers that are out there now, PEEK or pectin. Those types of materials are very, very strong. They're great for internal strengtheners. They're lighter, but they're strong. They're almost as strong as metal, and it really works out well. And you can see some of these designs here are pretty cool. I mean, the one in the middle with the open palette and the mesh going over the attachments, that's a beautiful design, So there's a lot of options out there for these different types of materials. So we mentioned before about divergency issues with the Locator attachment. It's the same thing with Ryan 83. When you have divergency issues, there's something called a smart box, and you can do up to, I think, 30 degrees of divergency to correct with these types of attachments. So this works out very well too. And then utilizing a rotational cap similar to the one that we showed before with the locator attachment. And this is going to eliminate any wearing of that attachment, and because, if those implants are divergent and you take that denture in and out of the mouth, it's really going to wear those pretty quickly, those nylon attachments. So just something to take into consideration. So that's called the Smart Box by Ryan 83. Those are just 3 systems out there. There's dozens of systems out there for attachments. So there's a lot of choices to choose from. I just don't have time to talk about every one tonight, but pretty much used every one in my career. They're making these types of dentures. So let's look at overdenture milled bars here. You have a choice of what type of bar to have. Most of the time we're getting overdenture milled bars with either Ryan 83 attachments or the locator attachments, and once in a while the ERA attachments. So. And these milled bars come out beautiful. These are titanium milled bars with 2mm threads. We just screw these abutments into the attachment, and then we can start our denture. So there's a lot of things you can utilize out there. There's another milled bar attachment, locator attachments, milled bar assembly. Once in a while we get a Dolder bar. I don't get too many Dolder bars anymore. As you can see here, this is a Dolder bar attachment assembly over a bar, a milled titanium bar. Very nice case. I mean, it'll work out well, but I'm just not getting too many calls for that, So, and then you have your hater clips. Everybody's familiar with hater clips, and sometimes I'll do a combination with a hater bar and hater clips and Ryan 83 or locator attachments. It really works out well. Really superior retention and a great case that's going to last a long, long time. So we're going to jump from overdenture cases into all-on-4, all-on-6, or now they call it all-on-X. So we'll talk about those types of cases now also. So I wish we had 2 or 3 hours to talk about this, but we only have an hour today, so I'm sorry I don't have enough time to really get into the overdentures more. But let's get going with the all-on-4, all-on-6 type of cases. So when looking at these all-on-4, all-on-6, or all-on-X, tilted implants with 4 or more implants are present. So in the posterior, most implants are tilted at 45 degrees or less. So, and that's at least with 4 implants. And it's a graftless procedure. Bone grafting is avoided by tilting the posterior implants and utilizing the available bone. So it's for the immediate function for a fixed provisional denture or bridge for those all-on-4, all-on-6 placements with immediate load type of cases, and also with full denture conversions chairside the day that these implants are placed. So when you're replacing the vertical implants with 6 or more implants, it's a vertical without any of those angulations on the posterior implant. So the sinus grafting may be necessary on these type of cases. So, and here's some just all-on-4 treatment facts. It's a proven long-term solution with high survival rates, and midterm, about 3 to 4 years, about 100%, 96 to 100% success rate, and 5 to 10 years, about 94 to 98% success rate, which is great. And has favorable bone and soft tissue parameters, and healthy soft tissue both for tilted and axial implants. So it's worked out well. This is just a radiographic image of an all-on-4 case here, as you can see. And a lot of times we're utilizing the multi-unit abutment concept with these types of cases. And it's carefully designed to rehabilitate both the edentulous and partially edentulous arches. And there's a short cone for limited interocclusal space, which works out well, and wider shoulder for easy positioning of the prosthetic restoration. And they come in both straight and angled 17-degree to 30-degree variants. So I always try to, encourage, some sort of surgical guide with these cases. I remember in the beginning when I first started doing these types of cases, some cases didn't even have any surgical guides. So I strongly encourage some of the 3D planning software that's out on the market today. There's a lot of choices out there, but through cone beam computer tomography or CBCT images, they're designed to prepare the osteotomy and perform the correct implant placement utilizing appropriate sleeves. So let's look at the 4 major steps for this planning. We have the diagnostic data acquisition, the virtual planning, the surgical guide production, and the surgical procedure. So with the diagnostic data acquisition, we look at bone volume. It gives us information about bone density, the anatomy of the area to be restored. We have to consider the type of restoration that we're able to utilize, and type of loading, number of implants, aesthetics, and function. So all this is done with our diagnostic and data acquisition. And image technology for precise digital plan and implant placement. So That's very important. And, you know, an impression can be taken conventionally or digitally with this. If it's a conventional impression, we can scan and merge it into the files of the diagnostic data acquisition. And then we have our virtual planning. You know, so we utilize a 3D data set or a DICOM, and it's imported directly into the appropriate planning software. Then it's merged and scanned with the impression or the STL file, and the implants are positioned in accordance with the patient's anatomy and desired outcome. So everything is being done for us virtually here, and with the planning, with the virtual software, so we know exactly where those implants are going to be going. And there's a surgical guide production can be done in a laboratory, or many times the implant companies will print these surgical guides for us also. So the surgical procedure, first thing we want to do is secure that surgical guide, prepare that osteotomy line with the recommended implant surgical instruments, and then the proper guided surgery kit in conjunction with the surgical protocol and the surgical guide indicate which instruments are needed at each site. And these instruments, along with the surgical guide, allow for the guided insertion of the implant. So it's very predictable time after time, and it really works out well, you know. So some great software programs out there, different companies selling these different surgical procedures and software techniques, so which is great. So what's the dental laboratory's role in all this? So the case planning on implants and the denture type and occlusion, we're there to help support you. We work closely with the dentist, the oral surgeon, and the implant company to plan these types of cases. And then the day of insertion or the day of surgery, we give in-office support with denture conversions, and then future case planning with the mill bar prosthesis. So the day of surgery, a certified dental technician will come into the dental office and will assist you with a step-by-step procedure in converting that removable prosthesis to a screw-retained denture. And this could be an existing denture. It could be a brand new denture where the patient had extractions or an immediate denture. I think the majority of times I'm doing conversions, it's with an immediate denture where the patient has extractions of their natural teeth. Implants were then placed, anywhere from 4 to 6 implants on the maxillary and 4 on the lower. Sometimes I get 6 implants on the lower. And then we'll do a conversion. You know, we'll do a conversion in office the day of the surgery. And I'm just going to go through the technique that I utilize for this type of procedure. First thing we're doing is taking the denture, the immediate denture or the existing denture. We're going to fill that provisional prosthesis with a heavy body of EPS material. We're going to insert it in the mouth, seat it in the mouth, and we want to make sure that midline is consistent with the facial midline. And then when you take it in the mouth, after it's set, we know exactly where to drill those holes for those temporary cylinders. So we have those indentations. So I'll start off with like a small number 8 burr. I'll go right through where those indents are, and I'll start drilling larger holes until I have it a little larger than a temporary cylinder. Then we'll place the temporary cylinders on the low profile abutments and make sure all the cylinders are completely seated onto the abutment. And at this point, we'll start fitting that denture over these temporary cylinders to make sure there's no friction or any interference. I'm going to try in the provisional prosthesis over the temporary cylinders, relieve any acrylic resin that's going to be interfering with these cylinders. And then we want to make sure that the provisional is completed. So at this point here, if it seats very nice, it's sitting completely with no interference, take a Sharpie and mark on those temporary cylinders right near the occlusal plane, or near the palatal area, put a mark there. So what's going to happen now, you're going to take the denture out of the mouth, you're going to take those temporary cylinders out, and I'm going to cut them down to that mark that we utilize for the Sharpie. This way the patient can bite into centric occlusion or the correct occlusion when you're processing those temporary cylinders. So as you can see the photo on the lower here, that upper denture here, everything's open nicely, and we're ready to process these temporary cylinders to the denture base. So make sure the rubber dam covers the surgical sites. There's no acrylic resin will come into play. I'm actually not using acrylic resin anymore. I'll show you the material that I like to use, and I recommend it to clinicians. It's not monomer and polymer anymore, which can run over all of the mouth and lock things into place. It's a different type of material, and we'll talk about that in a minute. And I use an auto-polymerizing acrylic resin around the base of the temporary cylinders. So what we do here is paint a primer only where you want that acrylic self-polymerizing resin to adhere to. And don't get too brave on this, because I've been in instances where the clinician says, you know, I can cure 6 of these at a time and have the patient bite down. But the material on an average takes anywhere from 1.5 minutes to 2 minutes to cure. And with the warmth in the mouth, it's going to cure sometimes faster. So I would recommend maybe doing 2 or 3 cylinders at a time. Have the patient bite down to the place into centric occlusion and make sure everything is correct. And then have them open up and you can cure the rest of these sites. Yeah, that's the way to do it. So, and there's a lot of different materials out there. One of them is the chairside attachment processing material from Zest that works out really well. And it's an auto mix material. And, you know, there's no running, there's no heat buildup, there's no taste, no smell, and it cures in a matter of a couple of minutes. And then this is one of my favorites here also. This is called Quick Cup. And instead of using cold cure acrylic, this Quick Cup comes with a couple of different cylinders. And one of them is a cure auto mix material with a primer. So you paint that primer on, put that auto mix material around the cylinder and the acrylic. And once you take that denture out of the mouth, and if there's some voids on the tissue side, there's a light cure material also where you can inject and light cure for about 30 seconds. It really works out well. It's strong. It looks like acrylic, and it holds things in place really nicely. So instead of cold cure acrylic and soft cure acrylic, this is what you should utilize. And then at this point, you know, everything looks good, we take it out of the patient's mouth. If it's an upper, I'll cut out the palate, I'll cut down the borders, polish it, and the patient's ready to go. And you know, you think about this procedure, and you know, when I first started doing conversions, I'm saying to myself, man, this poor patient, they're getting extractions, they're getting implants placed, then they're going to the general dentist, you know, and from the oral surgeon, general dentist, then they have to sit in the chair for 3 or 4 hours while I'm doing this conversion, and then they walk out of the office. So you figure there's a lot of work to be done in one day. But let me tell you, a lot of the patients I see, they're ready to go. I mean, they're in such good spirits, and everything usually works out really nicely, you know. And they're going to be wearing this prosthesis, this temporary prosthesis, probably for about 4 to 6 months. Then we can plan whether we're going to do a hybrid type case with a denture or a fixed type of case. And this is just a couple of photos intraorally with the you know, temporary cylinders and doctor curing this in place with the post-name. Nice, that worked out. All in 4 cases. Doctor's happy. He's got a bottle of champagne ready to celebrate. And let me tell you, it's a good feeling. After going through all this planning and seeing everything fall into place like this, it is a really good feeling, and seeing the patient happy with these types of cases. So, and to go one step further, I want to just show you a little bit about the printed technology for hybrid transitional dentures. So what we did here, we actually utilized the guided surgery, the guide that we used for the guided surgery, and we utilized that, and we utilized it for our traditional hybrid denture. So it gave us exactly where those temporary cylinders were going to be. So we didn't have to worry about drilling those like I just showed you earlier, taking an impression inside the denture, drilling the holes out, everything's done for you. You know, so you can leave the palate in there, you can cut the palate out, save a lot of time. And probably you wouldn't even need me in the office helping you out with this conversion here. So we're going to send this to you with, you know, utilizing the surgical guide with all those holes ready to go to cure those temporary cylinders into place. And this is the final denture, as you can see on the right-hand side. So we can either have the palatal area done, still in there, or I like the way that we did this on the right-hand side here, which is we're ready to go and insert it into the patient's mouth with the access holes. So great technology. So let's talk about patient expectations. Let me just check my time here, make sure I'm okay with time. Good, great. Patient expectations on these cases. But let's look at the relative functional jaw capacity of the lower jaw. Now, with all natural teeth, it's about 100% capacity. You know, with an implant-born bridge or screw-retained hybrid type denture, it's 90% capacity. Your implant overdentures is about 60%, and we go down to a lower denture, which goes all the way down to 10%. So it's amazing when you look at this this study that was done by Dr. Braz, and it was done in 2002 actually. And I like to show this because it just shows that relative functional capacity of the lower jaw with an implant overdenture and with an implant screw retained denture. So let's look at some special considerations here. Of course, you want to have the adequate bone quantity we need for these types of cases. Bone height, you know, more than 12 millimeters to at least 10 millimeters height in dental implants. Bone width about 6 millimeters to allow for 4 millimeter diameter implants, and limited grafting can be accomplished at the time of implant placement. So We need adequate restorative volume, about 12 to 15 millimeters on these types of cases. So we'd love to get that 15 to 16 millimeters when we talk about the adequate, intraocclusal space. So, and the adequate AP posterior spread for optimal positioning of implants. And like I mentioned earlier, the adequate coverage of the lip to hide the transition zone. So I just wrote an article for JDT Magazine, Journal of Dental Technology, on this, really elaborating more on the transition zone on these types of cases where the patient had to get an overdenture as opposed to a screw retained denture. So some of the treatment precautions, the patients, let's look at those systematic health complications like bleeding disorders, metabolic diseases, diabetes, things like that, compromised immune system with HIV and autoimmune diseases, and parafunctional habits. So all these things have to be taken into consideration before we go into these types of cases. And precautions are lack of bone quantity, limited arch curvature to poor AP spread, bone less than 12 millimeters, bone width less than 6 millimeters. All those things have to be taken into consideration, or we can't do these types of cases. And a high smile line. So we talk about anterior posterior spread. Intentionalist patients expect posterior first molar occlusion. So treatment planning, the position of the implants, and following the protocol for AP anterior posterior spread can achieve this result. So what we do, we measure the distance in millimeters between the anterior implant and the most posterior implants, like this diagram here. And we take the measurement and multiply it by 1.5. And this number offers you the distance that teeth can be cantilevered off the most distal implant. So it's really important to follow this. And a lot of the case planning with software with bar design, it's done automatically for us. But just take into consideration when you're planning these types of cases, the AP spread. So restorative space, it'd be nice to have a lot of restorative space like this here. We have plenty of space in this particular case here. So we don't have to worry about those 16 millimeters. I'm sure we have it here, this one here, I'm not too sure. We might have to do some bone reduction here on the left-hand side. So, so some challenges here when you're planning these types of cases. So when we talk about restorative space, like I said, we'd love to have 12 to 15, 12 to 16 millimeters. And you look at the breakdown here, the abutment is 3 millimeters, the hybrid bar, we need 3 millimeters, space between the tissue and the bar, 1 millimeter. Acrylic, if we're doing a hybrid acrylic type case with a denture, at least 4 millimeters of acrylic we need. Sometimes I don't get that. And the teeth, about 4 millimeters too, of thickness on the teeth. And many times we don't get that. And that's where you run into breakages. I was just talking to a dentist recently. He said, "Dennis, I stopped doing these types of cases because I have teeth breaking off and acrylic breaking off." And we went through the protocol, and it was because a lot of these things were done with less than 2 millimeters of space here, and you can't really utilize that and have a successful case with these types of cases. And the transitional line, the junction between a natural pink and artificial pink, and is affected by lip mobility, smile line, the amount of bone, and the size of the teeth. And then tissue contact. I try to leave like a millimeter or maybe to 2 millimeters of space between the hybrid bar or the acrylic and the tissue. Sometimes the doctors tell me, "Dennis, I'll take the I'll get that I'll eliminate that in the operatory. I'll grind it down." But sometimes we can have an effect like this patient had on the lower picture here, with some irritation. And sometimes the patients, they're allergic to acrylic, and if that's too much contact, creates this type of effect here. So it's important to follow the protocol. Don't deviate from the correct protocol in these types of cases. Start with a preliminary impression. That second impression is going to be final custom tray, maybe an open tray. Most of the times when we talk about open trays, it's because those impressions those implants are divergent. So from the final impression, I'm going to make a master cast for the soft tissue model. And then at the same time, once we make that master cast, we're going to do a verification index in the base plate with the bi-rim. And sometimes I put a couple of those temporary cylinders in the bi-rim just so it can stay in place. And then we'll do a tooth setup. If the verification index worked out well, we do a tooth setup and everything looks good with the occlusion, and we're ready to get our bar made. And we send it out to whatever company's milling our bar. And once that bar is sent to the company, a few days later, we'll get a verification JPEG and make sure the design looks good. Then we'll do the bar try-in, the tooth setup on the bar, and then we're ready to finish the case. So following this protocol is really important. Again, let's for the review. Soft tissue master cast from impression, fabricate that verification index and the by registration, verify that master cast is correct, And then we make our bite block. And, it's important when we're making these occlusal rims, make them the same way that you would make like you're making a upper or full lower denture. But we need the information on the upper rim like we got on like a full denture. The midline, cuspid line, the high smile line, all that is needed for us to do a correct setup. And this is the verification material I use. I use this material as Prima-Splint. You can use any light cure material. You can use Duralay, a lot of different materials out on the market. I happen to like this because I can wrap it around the temporary cylinders, put it into the light curing unit. There's no shrinkage or expansion. It cures within 2 or 3 minutes and we're ready to go. Everything looks good with the verification index. The teeth is set in wax for a denture try-in. So I'm going to stop right there and I'm going to go talk about setting the denture teeth. I'm not going to get too involved because that's a whole other course on its own. I like to use a semi-adjustable, a fully adjustable articulator with these types of cases. And when I set the denture teeth, we ask ourselves, how do we select anterior teeth? Well, facial form equals tooth form. And we look at this face here on the left with breaking it down into sections here. We have a pupil line, which is equal to the occlusal plane. We have a smile line equal to the Camper's plane. We draw a midline, cuspid line, and we have a smile line there. So all this is important when we're setting our denture teeth. So how do we select those anterior teeth for the patient? So we have to determine the mold by the shape of the arch. And this is how I picked that denture. If you look at the shape of the upper arch and hold it in front of you, it looks like the shape of a central. So it could be ovoid arch, a square arch, tapering ovoid. So all these years I had in this industry, I go by the arch. I go by the shape of the upper arch to pick out my upper anterior teeth. Or you can use a study model of the existing denture. Or you can measure the 6 anteriors by on the cuspid lines on the bite block, from cuspid line to cuspid line. And it gives you the amount of millimeters from cuspid line to cuspid line. Then you go to the tooth chart that the manufacturer provided, and it gives you the exact type of anterior tooth to choose. So some of the concerns are the width, the shape of the centrals, and of course the shade. But tooth form equal facial form. Usually we have a square face, we have a square central. Square tapering central, and so forth. Ovoid central. So that's been the rule of thumb all these years. And if you look at the tips of the canines, usually equal to the width of the nose. And the width of the centrals are equal to the width of the philtrum. We want to set denture teeth to replicate nature, something that's harmonious and aesthetic. So when we're setting up our anteriors, we want to use the correct denture teeth. Like I mentioned earlier, there's a lot of denture teeth out there on the market, but especially for implant type cases with overdentures and these hybrid cases, denture teeth tend to wear a lot quicker than they would on a regular denture. And this is why I recommend something that's going to have ceramic fillers or something that's going to wear like natural denture teeth. So you want something like a microfiller reinforced polyacrylic, something like this is from Vita. And it's a special material with ceramic fillers. They look great in the mouth, they wear great, and it's homogeneous material throughout the entire tooth. So same size as natural teeth, high wear resistance, and it has lingual anatomy for better phonetics. And as you remember in the beginning of the presentation, I talked about phonetics, especially with newer denture patients. They have trouble speaking. Their tongue tends to slide off the lingual of the anteriors. They lisp a little bit. It takes them a while to get used to that. So I like teeth like this. These are some dentures that I made, and you can look at the lingual here, and they have a rugae, and they have lingual anatomy on the anteriors. And beautiful denture teeth that's going to feel natural for the patient and help in phonetics. Aids in chewing and swallowing. We want a wider occlusal surface on the posteriors for implant cases. So when we're setting our denture teeth, we want the anteriors positioned individually and parallel to the pupil line. So this is why I love to get a Facebook transfer on these types of cases when I'm doing full mouth reconstruction. The lower incisal edges are also parallel to the upper incisal edges. So we're setting our upper anterior teeth, and once we got those set, we're ready for our posterior teeth, and we have to figure out what kind of occlusal scheme we're going to use. So 72% of laboratories use semi-anatomical and anatomical teeth. You don't really want to use a 0 degree or 5 degree tooth on these cases because you want the patient to tear and chew their food, not grind, like a cow, so that's slide like a cow. So most of the times I'm using lingualized occlusion. So here's some of the different combinations of occlusal schemes here. You can see a lot semi-anatomical, anatomic combinations, which I used to utilize years ago with lingualized occlusion. We used to use a higher degree of tooth on the upper and a lower degree of tooth on the lower. So when we're setting these teeth, we want to align the occlusal surfaces towards the center of the cranium. That's your curved Wilson. The only time I'm not putting a curved Wilson on is on the right-hand side here when I'm using lingualized occlusion. I'll have my curved SPI which is an anterior curve from the anterior to the posterior, but I won't have my curva Wilson going buccal to lingual because I want the lingual cusp of those uppers going into the central fossa of the lower, relieving any off-axis stress on the implant with lingualized occlusion. So the actual inclination of the posteriors are centered to the cranium, as you can see here. We'll follow the guidelines with setting the upper teeth over here now. A nice harmonious transition to the posteriors, and we have a completed setup. And this is one of my wax ups for try-ins. I try to really look, make it look like a natural finished denture here. So I use different colors. Sometimes I'll match the patient's natural gingiva on these types of cases. So it really helps out well. And I'll follow that with the final, when I do the final processing in the case, I'll do some denture-based stain to follow that exact guidelines of the try-in. So with lingualized occlusion, it's for the implant-supported overdentures. It's a reduction of the lateral side-to-side forces on an implant. Lateral forces could cause the implant to fail. And you can see the buccal plus cusp are flared out just slightly and out of contact with the buccal parts of the lower. And, you know, because of that buccal, a lot of times it's going to push away that cheek and eliminate any cheek biting also. Again, I'm waxing for try-in. I try to make it look natural. Which one you prefer, one on the left or the right? So, you know, we have diagnostic wax ups for crown and bridge. Why can't we have a nice characterized wax up for denture cases also? And this is one of my wax ups here. So now we're ready for step 5, and it's the intraoral try-in of the wax denture. And once that's approved, we send the setup, the putty index, and soft tissue model to the milling facility. And I always make a putty index of the setup. Yeah. This way we know what the distance is between the bar and the denture tooth. So in a matter of days, I'll get a picture of the bar. This is a hybrid bar here. I'll get a picture, a 3D photo. I want to make sure everything is correctly lined up. There's your access holes on the denture. So everything looks good. I tell them to go ahead with it, and we get our milled bar. And when it comes back to the laboratory, we can reset those denture teeth. A lot of choices. You have a wraparound bar, a round bar. I'm not really happy with these types of designs here. I like a good hybrid type bar, you know, like this, a hybrid design bar. And you know what I'll utilize. I'll put some opaque on there, and now the bars actually come opaque, so you don't have to worry about putting opaque on there anymore. So when it comes back to us at the laboratory, I really want you to try this in one more time to make sure the bar fits correctly and the occlusion is correct so we can go to a finish. So what I'll do, I have my denture try-in here. I'll make a putty matrix and I'll close that denture try-in into the putty matrix. And many times those denture teeth will come off into the putty matrix. And then what I'll do on my upper model, I'll put my bar on the upper model, as you can see here, put some nice soft molten wax in where the teeth are. And I'll just close my articulator till that guide pin hits the guide plane. And then I'll let it cool. I open it up and I have my transferred setup over to the bar in a matter of minutes. So this is a nice technique I came up with here. It really saves a lot of time. I'll wax up the case, clean up the wax and open the access holes. And then you can try it in one more time in the patient's mouth. Just a nice final wax up on the bar. There's a wax up on the Montreal bar here. As you can see here, a nice setup here, a nice wax up, ready to be tried in, and we can finish the case. So, but many times I'll, you know, when I'm processing the case, I'll mask the bar with a special material, and I use something called VMLC. I hear a lot of stories of cases breaking and acrylic breaking off the bar. I haven't had a breakage off a bar in over 6 years using this method. And what I'll utilize, I'll sandblast the bar, roughen up the bar. I'll use a metal primer and something called a pre-opaque. I put that pre-opaque on the bar, light cure it, and then I'll put my regular opaque on there and light cure it. And it creates a tremendous bond between the acrylic, the light cure material, and the bar. It really works out well. And this is how it looks before it's processed. This is traditional way of processing here. As you can see here, beautiful. And again, this is just showing half and half, you know, the opaque side and the non-opaque side. And then, you know, as far as denture processing, I'm not going to get too much into it, but I don't know how much time we have, you know, only a few more minutes here. I'm going to get, you know, but most of the time we're doing injection processing for these types of cases. And you want your denture base to look natural and a variety of gingival shades and great bronze to the denture teeth. Something that's going to be impact resistance and flexural strength and good finishing and polishing properties with color, fit, and stability. And then if you want, you can add denture-based stain. And what I'll do here, I'll prepare the surface, I'll roughen it up. After the denture is processed, I'll start adding some gingival stain. I'll light cure it, and I'll polish it. I try to mimic whatever digital photo I get with the patient's natural gingiva. I could achieve that by putting this denture-based stain. And there's your finished results. How about that denture base? That's a dramatic effect, right? With denture base, this is those are physiodense teeth, and it's a nice characterized acrylic with denture base stain. There's a picture of it in the mouth. We can't see the gingiva though with this picture. And there's the final denture there. We're going to wind up the presentation tonight here with an article that I wrote a few years back in IDT magazine, Inside Dental Technology. And this is a very special case to me. I talk about it a lot. And I got a call from a doctor in North Carolina, and Dr. Merrill called me up. He said, Dennis, can you come to my office? We have a special patient, 18-year-old kid, 17, 18-year-old kid at the time, going through high school with 2 orthodontic bands in his mouth and a denture teeth on a wire. In the case, he had a lot of congenital defects, and he went through a lot of operations. We really couldn't do implants at the time. So I looked at the case. I really didn't know what to do. And, you know, I brought it back to the laboratory. We decided to do some post-and-core attachments. And on these post-and-core attachments, I put some equator attachments, almost like an overdenture case. So I cast the post-and-core attachments. As you can see here, and polishing them up, we have the equator attachments that were cast right to the post-and-core. Doctor cemented these in the mouth, and we had, the doctor took an impression with the impression analogs. There's the final impression here. I poured it up. When I got back to the laboratory and poured this up, this is what I had to look at. And I was looking at this and I said, man, this is a tough case. You know, we have these attachments here, patients in malocclusion on bicuspids, almost a class 3 type of bite. What do I do? So I sat there for like an hour trying to figure out what to do here. You know, we knew it was going to be an overdenture case, but I came up with an idea. And I took some denture teeth. I did a setup, made a putty matrix. I said to myself, let me utilize a material. It's called duracetyl. It's a thermoplastic material to utilize as a framework for these denture teeth. So what I did, I injected this material. I took out some of the denture teeth out of the mold. I injected it with this duracetyl material. And then I put some a mesh type of design on the anterior so we could set these denture teeth and process them to this base. Worked out really well here. And so I set my denture teeth. This is the duracetyl material. All you see here is duracetyl material. I put some light cure material, composite, to give it a gingiva color, make it look more natural. I put like a little glaze material over the teeth. And you can see it really satisfied that malocclusion that we saw earlier. I don't have to worry about denture teeth breaking off here. But now I'm going to set my denture teeth and process it. And this is what we had here. Processed denture teeth, the duracetyl resin in combination with the acetyl resin teeth. And then we cured these equator attachments internally. And I was kind of worried about oral hygiene. So I took a material called Versacryl. And it's a soft liner material that softens up with the warmth of the mouth. And what happens with that is sealed any openings in the mouth. So it really gave the patient more of a situation where we didn't have to worry about getting food and trapped inside. So I finished all the case, sent it to the doctor's office. I was in California at the time. I got a call from Dr. Merrill. He said, Dennis, do you want to be here when we insert this case? I said, sure, I really do. All this planning here, all this work, and everything was done pro bono. We had all the materials donated from the different companies. We did it at the laboratory in no charge because they had some financial hardships to the family. I went in there on Monday morning, and Josh was there with his mother. This is Josh's picture on the left-hand side when he had this denture, and this is Josh on the right-hand side and with this overdenture case. It fit perfect. We didn't have to do any adjustments, maybe a little tiny adjustment on occlusion. That's about it. It took us about a second to do. And Josh's mother was, all upset, happy, hugging us and emotional. And then Josh said to me, he goes, Mr. Urban, I thank God for what you did. Now I know what it feels like to have my natural teeth. And really happy with the results we came. And then he turned around and he said, Mr. Urban, you think the girls are going to look at me now? And I said, oh yeah, look how handsome you look, And he wound up a few years ago, got married, and he's now a missionary, actually traveling around the world. So, we change people's lives, with what we do. And this was one of my favorite cases here. I'd love to talk about it. And this is the overdenture case utilizing duracetyl and equator attachments. With that, we talked about artistry through denture technology today and all the different materials and techniques that have made me successful and have made patients happy and dentists successful also. I want to thank you for joining us tonight. I'll be glad to take any questions if you have them. And I appreciate you joining us tonight. Thank you.
Thank you, Dennis. That story is always one of my favorites of your cases, too.
Thank you, Jessica. I appreciate it.
Josh does look so handsome.
Yeah, what a difference, right? Big night and day.
Yes,
Yeah.
definitely. And
Right.
as always, a wealth of material. We're ending right at the start of the hour.
Oh, okay.
We don't have any questions in the inbox, so I'll just throw one of the couple of the polls up real quick and see
Okay.
if that sparks anything from the audience.
Great.
Otherwise, after that, we'll say adieu.
All right.
So the first polling question here is, which attachment system do you feel has the best results? The Locator, the ERA, the Rhine 83 Equator, or the Bredent? And we're curious, which attachment system do you feel has the best results? The Locator, ERA, the Rhine, or the Bredent? And just give this a couple more seconds. 3, 2, 1, and end poll. So the Locator got 67%.
Oh, we had Rhine 83, 17. That's good. Bredent's still being used, and it's a good attachment also. There's so many attachments out there, and just different, so many different companies out there to utilize. So whatever works, whatever works. Yeah.
Great. So the next one we have is, in your experience with hybrid type cases, do you feel more comfortable with 4 implants or 6 implants on the maxillary? So we're curious, based on your experience with hybrid type cases, do you feel more comfortable with 4 implants or 6 implants on the maxillary?
I know what my answer is.
Which one is it?
Is 6, because if one fails, we still have 5 left. So.
Well, I ended early just to see if you matched, and 76%
Nice.
agree with you.
Great. Good choice.
And then we'll go to poll number 3. When performing chairside, oops, I didn't launch it. My apologies. When performing chairside denture conversions, would you like to have a dental technician helping in the conversion process, or would you rather do it all by yourself? I.e., would you like one of us there with you? Not me, though. You mean Dennis.
Be right over.
Or would you like to do it by yourself? So we'll just give that a couple of seconds. Actually, we could also send Lisa. Lisa has great technical experience and background, too. And the 69% would like a technician with them.
Thank you. I feel wanted now. I feel the love now. Thank you.
You needed, right?
Yeah, so feel free. Lisa and Dennis's contact information is in the chat box. You may reach out to them to see how they can enhance your learning capabilities. Okay, so then we have one more. Oh, we have a question come in. Can overdentures be provided to patients with malocclusion?
Yes, they can. You just have to write the right occlusal scheme, and you just get the right, different right cuspal inclination on denture teeth too. So it's according to what kind of attachments you use. Also, you want to do it in combination with a case that they're going to utilize an attachment that's going to be retentive. And I would say with these malocclusion, well, it could be different types of malocclusion also. So I would try to use malocclusion. Use anything from like a 15-degree tooth maybe to a 20-degree tooth on those types of cases.
Great, thank you, Dennis. And we've got another one. Do you prefer to use multi-angle abutment or customized abutments?
Oh, good question. Most of the time we're using on these types of cases, I always had the multi-unit abutments on these types of cases. That's what I'm used to. But I've done both. Both of them are great. They both work out.
You do have a vast experience with everything.
Yeah. I'm old. No.
And you started when you were 5.
That's right. Yeah.
Lisa started when she was 3. So she did beat you on that.
Okay.
We have another one. Somebody wants to know where we can find the products online we discussed. DSG does not post all of this information because we like to provide a wide variety of scientific content. We do have reference guides and materials available in our reference library. But Dennis, would you like to add in any more?
Yeah, I mean, if they want to just go, Google something, go online and check out the names of the products that I mentioned tonight, they can do that. So like I said, we try to be educational and non-biased on these, but this, I like to talk about what works also, and those products work. So you just have to go to the websites of those products that I showed, and they can utilize that.
Thank you. No more questions, but I can't go because we have one more polling question.
All right.
Which titanium milled bar have you had the most success with? So we're curious, which titanium mill bar have you had the most success with? Was it the Nobel, Procera, Panthera, Zimmer Biomet, or Dentsply? Which titanium milled bar have you had the most success with? And we're going to end in 3, 2, 1. It looks like Zimmer Biomet won with 33%, but pretty even across the board.
Right. Yeah. They're all good bars. Yeah.
And we did get one more question. What's the management for patients with systemic diseases mentioned just now when the patients wish to have overdentures? Yeah,
you said overdentures is much easier than you would have to, with the screw retained dentures. So I would probably go with an overdenture type of case. Many times we'll go even utilize root attachments, which I didn't show too much of tonight. So a lot of times for those systemic diseases, the root attachments work better. If there's any natural teeth left in the mouth, you can utilize that root on these overdenture cases. They work out really well. That's one of the solutions.
Thank you, Dennis. Looks like we'll move to close. No more questions and answers. Lisa, would you like to address the audience?
Sorry, I had to unmute myself. I was just like mesmerized by listening to Dennis tonight. We just want to really thank everybody that made it to tonight's presentation. And like Jessica said, please don't hesitate to reach out to us and keep an eye out for all of the education courses and webinars that we are having available for you. And please continue to visit us for those educations. Hear Dennis speak, as well as some of our other speakers that we will be seeing in the future. So as we continue to grow educationally, we really would appreciate continuing to see all of the people who have participated tonight. So thank you all for coming.
And we only learn and grow if you learn and grow.
Right.
And then I'll shoot it to Dennis.
Sure,
bye, everybody.
Very good. Yeah, thanks, Jessica. Thanks, Lisa, and thank you everybody for joining us, and I really appreciate it. It's it's an honor to be here and talk about what I've done all my life here and the success stories I've had, and to help you get these same success stories also. But hope you had a positive learning experience tonight. May you apply your knowledge and expertise in a positive way, in a way that will enhance your careers and your self-worth. Have a great day, and thank you very much.